So I think that we've covered the IAF. One of the things we're going to talk about now is the capacity and access payment. And this is the key stuff that many of you probably heard about, seen about, and talked about since the contract stuff came about, because this is where the changes have happened. So just to remind everybody, the capacity and access payment is what they have reconciled majority of the IAF funds towards. So if you look at the IAF from last year, IAF across the whole country was worth £223 million. IAF this year in totality is worth £305 million, of which we mentioned that £59 million is towards the IAF criteria, the ones we just mentioned in terms of vaccinations, learning disabilities, cancer care, and access in terms of ACC08. The remaining £246 million has been allocated to the capacity and access payment, which is what we're going to outline here. And this is split into two effective sections. It's got the national payment and the local capacity payment is what they're calling them. And the national capacity payment is the 70% that networks will get directly. This says unconditionally. It'd be really interesting to see if it stays unconditional, because
it's there in the contract.
Yeah, it does state in the contract, although as we've seen, they have a habit of changing contracts. And to be honest,
people saying this. Yeah, I was going to say this is a really interesting document for people to have a look at, actually. So this is actually the capacity and access payment guidance. It's for ICBs in terms of how they instructing them in terms of how they should be assessing and awarding the capacity and access payment monies. So it's really interesting to get your head around. And as Gandhi was saying, there's the two components. So I think Gandhi you just about finished saying that about the 70% funding, 172 million, unconditional is here in black and white, played to PCNs, proportionate to their adjusted populations. They reckon that that's worth about £11,000 per PCN per month.
And just to point out that this is now time and dated on the eternity of the internet for YouTube and that kind of stuff. So 1st of April, not April Fools. It is unconditional in terms of the amount that networks will get. And it works out approximately £11,500 per month per PCN based on a 50,000 patient population and stuff.
I was going to say, I've just jumped across just to access my notes here, actually. But in previous calculations that we'd done, we'd reckoned that this 70% payment for per patient works out about £3.07. For a £10,000 practice, if that went straight for practices, you're looking in the region of £31,000 per year. This is for a 50,000 patient PCN. If it's easier to think of in terms of per year, you're looking at maybe £154,000 per year. And if you're thinking about sort of place or city size, then that's probably about £350,000 per year, which I reckon is roughly ballpark 10 full-time equivalent GPs to deliver quite over a whole city footprint, to deliver what could be, depending on what assessment of need means, be quite a considerable ask in terms of access.
And then it talks about the local capacity access improvement payment. Now, this is the part that I think people need to be aware of in some way. It does mention that, so they've calculated it, I think it's £1.18.5 per patient multiplied by the adjusted population size of the network. And important to note that those details are also attached on NHS England. They've released a separate document to explain what the adjusted population is. It's a really weird calculation. I still can't get my head around it in terms of how they do it. So it's based off the weighted list size versus the raw list size versus some modifying factor. It's like a weird version of Cahill that doesn't make sense to me at all. But hey, they've calculated it, and they said this is what your population size is. So it's not raw or weighted. That's the important part to remember. And this is based on a couple of things that you have to do. The key one that many people need to be aware of is the first deadline, which is the 12th of May, that you have to submit your plan to the ICB about what your improvement plan is going to look like and stuff. And there is some guidance on this, isn't there, Andy?
Yeah, I mean, there's a really useful table for ICBs to tell them what they should be looking for in the improvement plans that they are collaborating with PCNs. So it's important here, just these plans are co-developed and co-owned with the system, so it's between ICBs and PCNs, so co-developed and co-owned. And if PCNs need assistance, then the ICB should provide that assistance in order to help them develop the plan. So if you need help, and then ask, in fact, I think everybody should be asking and collaborating with their ICBs. There shouldn't be an expectation that you just produce and submit, in my opinion. And then just interesting point here that they are looking for, or the expectation that patients will be treated equitably, can expect a response on the same day. Actually, just backtracking slightly, this was interesting, Andy. So it says the GP contract 2023 has been updated to reflect the different ways that patients now contact their practice, and whether this is in person or online. And it talks about some of the expectations around patients will be handled. And I think this might be referring to the contract that we haven't seen yet. So there might be a little bit of an indication in terms of what might be in that contract. Again, it's not clear. There's lots of GP contracts, aren't there? It's not quite clear which one it's talking to, but there's an expectation around people being treated equitably, independent of how they've contacted the practice. So you shouldn't be more likely to get an appointment if you come in and stand at the desk compared to if you ring up, compared to if you complete an online e-consultation. That people can expect a response on the same day that may include information, signposting to another service, for example, community pharmacy. It says, and this would be based on assessment of need. That phrase is here again. And it says that patients seeking routine care should have an appointment within 2 weeks of contact where appropriate. So this might be an indication that there may be more around 2 weeks in the core contract update. But again, it's not really clear here. But I thought that was an interesting passage.
Yeah. Definitely interesting. And I've asked the question in the chat and stuff. So would people be going forward with ACC08? And we've got loads of other comments coming through, but we'll come to those in a second. I guess before we get to that, we did want to focus on this whole improvement report part, didn't we, Andy? And
let's do that, and then maybe take some of the questions and have a discussion around things. So the plan covers 3 key areas: patient experience of contact, ease of access and demand management, and accuracy of recording in appointment books. We're just highlighting that the deadline for this plan is the 12th of May. And then I think probably the best thing is to actually just skip to the plan. Done some better quality screen grabs here. Gandhi will probably ask me, can I make it bigger? And unfortunately, we can't make it bigger on this view, I'm afraid.
Let me just see if I can do something that does help there. So that should make it a bit easier for people to read. So we've split this a little bit. Go for it, Andy.
Yeah. So the plan needs to be done by the 12th of May. That's the first thing in this table, and then assessment. They will then assess achievement to this plan in deciding the awarding of the final 30% of the payments. So that's interesting. In fact, just backtracking slightly, there's this statement within the document that if an underspend is anticipated within that 30%, then that money should be spent on other activities to support access to general practice. And I think we were just going to talk around that briefly, weren't we, in terms of what that might be, because that could mean money spent in general practice and on general practice, or could that mean walk-in centers, or supporting other ways that people access GP-like care within the wider primary care system? Do you have any interpretation of that, Gandhi?
No, I think that was one of the things we were concerned about, that because it's in the purview of the ICBs to allocate whether or not networks get these particular monies. And remember, we're talking about £1, 18.5 pence per patient. So for a 50k population, we're talking about £52,000 roughly of additional funding. Would the ICBs be in their best interest to allocate that based on the plans, or would it be in their best interest to, I don't know, put it somewhere else? Because we know that many ICBs have been told they have to make 30% cost reductions moving forward. You can understand the pressures that they would be under to achieve that. So it raises the question, how could this be done? And you would hope that networks that have been able to do this properly and effectively absolutely get the funding that they should deserve. You can raise absolutely the question whether it's appropriate enough and stuff to do it. That's a separate question. But I guess, could this money be directed, like you said, Andy, to other places like urgent care centres, pharmacy support systems, other kind of things which would help with access, in some way, shape or form, but back end existing plots or lines of funding already that may exist to support the fact that there's going to be a funding gap across all ICBs pretty much. I don't know. It's
I would hope that the
weird.
principle of additionality applies to this money, as it does to ARS staff and a lot of what PCNs do, but we'll have to see. So interesting points here. So you have to make the plan. Progress is judged against the plan. So judged against the plan. It also says where an agreement was made to participate in a support package as part of the support level framework. Progress made as part of this should be used by the ICB as part of the assessment of capacity and access improvement payment. So I think this is interesting because it's saying that it's an agreement between the PCN and the ICB. So I guess both parties have a say in what the agreement looks like. And I wonder if in some areas this might mean the ICB sort of buying in an assessment or support from an outside agency, or telling PCNs that they need to take a certain approach in order to receive the funding. I just wonder if there's a risk that happens. I use the term risk loosely because that might be suitable in some areas, but just with some careful interpretation of that, I wonder if that might be what happens. So the plan needs to be done, and then 3 areas. The first area is patient experience of contact. So this is interesting, and they're going to use GP patient survey data, and they tell us which questions they're particularly interested in as a basis for structuring improvements against. And they say to look at the trend over the last 5 years in terms of informing the plan. They do acknowledge that actually the general practice patient survey responses next year will be out too late and beyond the time at which they will be judging progress against the plans. So they can be used for planning, or should be used for planning, but cannot be used for assessment, which is.
And they specified particular questions here as well, isn't it? So question 1, question 4, 16, 21, and 32 in particular they'll be focusing on. But as you said, Andy, the key issue is that the data they get to benchmark it from to start off with is published after the 12th of May deadline. And obviously the reciprocal data that would have next year to see what changes have happened will be published after April next year, which is when all the funding has to be used and spent. So it'll be too late. But I think it's, like you say, it's more using your historic GP survey data potentially to direct you in terms of what things to focus on and where to look at and stuff.
It's interesting. Maybe we've just articulated for the people who are listening and not watching. So question 1 is generally, how easy or difficult is it to get through to someone at your GP practice on the phone? Question 4, how easy is it to use your GP practice website to look at information or access services? 16 is, were you satisfied with the appointment or appointments you were offered? And question 21 is, overall, how would you describe your experience of making an appointment? And 32, overall, how would you describe your experience of your GP practice? So those are the sorts of things you'll be judged against. Now, the interesting thing here is, Gandhi, it does say there are other ways that you can collect data about the experience. So they particularly mention friends and family test scores and using those. And they also mention asking other questions as well. So it might be that you can collect your own data briefly to these questions and potentially demonstrate some improvement, although the collection methodology would be entirely different. So quite how you can compare one set of baseline data with your own data is a very good question. So I think it will be difficult in some. I think you could maybe do things in such a way that you demonstrate an improvement, but is there genuine improvement there? You won't know until the GP survey data comes out.
So I guess if you're being asked to capture it yourself, then obviously it's how you capture that data and what methods you use. I know you did some amazing work previously about real-time collection of data in your practice.
Well, we've just been doing it for a long time. It's really routine for everyone now, I think. But after every single appointment, we just send people a text message and collect some feedback data, including friends and family. And it's a really, really interesting exercise. And we get, for a population of about 9,000 patients, we get 40, 50, 60 responses per month, which is quite a decent amount, really, and certainly adds up to more responses than we get on the GP patient survey, for example. And those are people who we know have just had an appointment with the practice. So there's an expectation within the plan to collect the data, process the data, analyze the data, and also act on feedback. So this is an interesting sentence. Process within the PCN. So this is PCN level reflection of that data, and act on feedback. So I do wonder what that might mean, for a PCN if one practice is getting particularly bad access. Feedback. I mean, this is a new dynamic, isn't it? That the PCN is responsible for individual practice performance potentially, and how does the PCN respond to that? Previously this has been a sort of a contract enforcement type issue, and that's sat with the ICBs or the local commissioning mechanisms. So I think that's interesting. This whole thing is done in collaboration with the ICB, so maybe you can pass that back to them, but it certainly looks like they're expecting a PCN level response. So I think that's interesting. Any further thoughts on that first domain of patient experience of contact, Gandhi?
No, I think you summarized everything. I think maybe one thing that come through is maybe we could do an episode on how you could capture data more effectively with your patient population. So I think if our EGP learners watching us, we've got over 100 of you live at the moment, so definitely jump in the chat and let us know. But if you were interested in knowing about how to do that, let us know, and we can obviously look at having an episode on that in the near future, hopefully. It then, however, talks about the accuracy of recording appointments. And we mentioned this earlier when we were talking about AC.
Well, Andy, number 2. So there you do have so 3 parts.
Oh, yeah, sorry. Apologies, Andy.
Ease of access and demand management.
Yes.
And actually, one of the big things here is it's talking about cloud telephony. So we were interested by the prominence of this within both the previous kind of letters and announcements, because it was one of the big bang announcements in the letter that we reviewed when we were in Harrogate a few weeks ago, and it's got a lot of prominence here as well. I know we were talking to friends of the podcast, Ben Gowell and Tara Humphreys, in a private conversation, and we were developing some theories about this, Gandhi.
Well, it's interesting because it's very much directed that you have to go to particular providers to have cloud-based telephony, which have been approved by NHS England. And it mentions about the concept of whether there's data packages being used, data analysis packages being used. So it raises the question, how are they capturing this data? Is it soft data based off number of calls dropped, calls made, that kind of stuff? Or are they actually going to be listening to recordings of calls? Because actually, to a degree, the only way you can find out if a patient was off an appointment within a specified time frame or where they were directed to go and stuff is to listen to the calls. And number one, how are they going to do that for the volume of calls that happen in general practice? Where have they got the staff to analyze that? If they're planning on using AI, what are you going to do for when it's non-English and all the other kind of complication stuff and things that come into play with that? But it just raises the question of what kind of data they're actually going to be using. I think we kind of figured it probably is going to be the soft data. So it's the data of, if you have loads of calls to your practice, and then reciprocally you have very few appointments booked, and then there's loads of people attending A&E, are they going to infer that that's an issue? Whereas, is it correlation? Is it causation? Gosh, yeah. I think there's going to be a variety of different options and stuff. There's an interesting one put in the chat. I'm going to mention it right now, and it's from a good friend of ours, Lisa Drake. Secret shopper for call experience. It wouldn't be, a far cry to do. And
Our
stuff.
CCG has done this in the past, many years ago. I know that they did a secret shopper exercise. So I think there is form for that. I think it was interesting what you're saying, Andy. I think they're maybe looking for an additional data point about call volumes that they can put together with GPAD data about number and types of appointments, and maybe even, how your patients are accessing 111 ED, other areas of the system to imply your compliance with ease of access and demand management. So really, really interesting. The other part to ease of access and demand management is about having online consultation methods in place. So there's 2 bullet points here that it suggests as a starting point, and is an online consultation function in place, and then looking at the number of online consultations per 1,000 registered patients, and then making some plans around that and looking at that over the course of the year, which I think is an interesting one. And practices will be seeking to get that number of appointments per 1,000 in the right place, because I can foresee some circumstances where that could be interpreted as being too low for a given type of population, and some circumstances where that was interpreted as being
Too
too
high.
high. So I don't think
Yeah.
it's one where, increasing that number will always be appropriate everywhere.
Mhm.
But I guess this is an individualized plan for particular primary care networks. So hopefully everyone involved will appreciate the nuance. That was interesting. Anything else about that, Gandhi?
No, I think that's everything.
No, it's fair enough. And then
Mhm.
finally, accuracy of recording in appointment bookings, which I think relates back to ACC08 that we were talking
Yeah.
about earlier, and the collection of data against using the approved categories so that it can be categorized and displayed on general practice access dashboard. Actually, it does mention triangulation here, doesn't it? ICB assessment based on self-certification and triangulation with PCN's appointment recording seen via ICB GPAD dashboard. So that use of that word triangulation, I think, suggests multiple data points to infer performance. Any further thoughts on this?
So I think if I remember rightly, this also lists some of the parts where it talks about, and I don't know, Andy, if you can find it on the screen share. It also mentions about the PCN approval of access to data as well. And this was an interesting thing because in some places, it may be in the detail itself. I know in some places they were questioning why they were being asked to provide PCN level data for the appointment stuff and things. And it looks like this is a direction that actually this is something you have to do. It may be in the annex and stuff.
Yeah.
I remember reading it and stuff. So all but yeah, GPAD sign up to this was it. Sign up to the GPAD appointment data provision thing. PCNs need to sign up to this in the participant, not just practices, but PCNs themselves. And I know locally in our area, there's been some discussion about actually that they didn't want to do this. They didn't see why they had to do this. And it actually is now outlined in the PCN DES contract that you have.
It's a contractual requirement now. Yeah, it's a contractual requirement to do it. The document we're currently in is guidance for ICBs, but it's PCNs need to complete. So it's pretty strong, isn't it? But it's moving. It's giving us a little bit more. It's not just looking at reducing variation in clinical quality around practices, which is something PCNs have been working on, but this is really about performance to contract, which is an interesting responsibility for PCNs or neighborhoods to be taking on board. So I get, but what are PCNs being asked to do? So record all appointments in appointments books in line with the agreed definition of an appointment. That's something we've all been working towards, and NHSE and BMA have guidance around that. PCNs need to have signed up for the PCN level data at GPAD, and needs to be working towards improving the accuracy of appointment recording towards existing guidance, and I guess performance to ACC08 is certainly part of that. Improve the use of GPAD to differentiate urgent from routine appointments. And I guess the ICBs, NHS England, it's in all our interests to have better quality data, I guess. So this isn't necessarily a negative thing. This is where they make reference to ACC08 in particular. Routine appointments offered within 2 weeks of contacting the practice should be coded according to guidance ACC08. So this is where at the moment, this looks like it's just about recording of those appointments and paying for the recording, a fairly small fee for data quality. We don't know if there will be something in the core contract that is firmer and stronger around 2-week requirements. And then they talk about technical support that's available to ICBs and in turn available to primary care networks to support them with achieving these data quality targets. So
there we go. But I think one of the key things to think about, if you wanted to try and achieve this, one way of potentially doing that, Andy, is just simply moving towards, a total on-the-day triage system, actually, because then you code all your appointments to on-the-day urgent stuff, and there you go. You've hit ACC08 effectively.
Yeah, but are your patients going to be happy with that? Because I mean, we and you and many other people out there may have tried similar things in the past, and often actually patients are less satisfied with that because some people value being able to make an appointment in the future, be that 10 days or or 18 days. I mean, it's really difficult.
And I think it's one of those things, isn't it, that they are focusing absolutely with these documents that access is the priority and not other parts of care in terms of continuity, in terms of, quality. Even you could argue that, all they care about is access. And that's what it's going to look like potentially. But, if you're looking at an option, that would be how you comply with the contract. I guess the question of what other actions should people be considering? Well, I guess there's a timeline that we do know about. So number one, that, in terms of there's stuff around mapping your appointment data, making sure that's correct. And that's along the lines of GPAD and the various other things, mapping them to the acute and chronic appointment slots and that kind of stuff. There's the improvement report to be done across your network. Timing for this is really, really awful. Let's be honest on this point. We're just about to hit the Easter holidays, so practices are going to have obviously limited number of regular staff because it's a natural break. We also then head into May, where we've got 3 bank holidays in May in addition, so that's going to have some impact on people being able to collaborate stuff. And rather interestingly, the report, if you look at the original letter that came out on March the 6th, suggested that you would have a 3-month period to do the improvement report. That's now been taken down to 6 weeks in terms of the time frame that networks have to provide this improvement report to the ICB. So effectively, you've got 6 weeks, of which, let's be honest, we'll lose about at least 2 of those because of the Easter holidays and everything else that's happening, to create a report about what your network plans to do for access and improving access and providing access in collaboration with your ICB.
In collaboration with the support of your ICB and your locality teams as well. So people shouldn't be thinking they need to do this on their own. An interesting thing, Andy, that I notice is kind of what's not suggested in the report or within these documents, and people are not suggesting PCN neighborhood level acute care services or streams. These are things that were in the fuller stock take, for example, and we've seen in other documents. And those are the sorts of things that I guess people might choose to do as part of their plans, but it is not. I've not seen it mentioned in anywhere within any of the package of documents that we've seen come out as something that is not even a requirement, but a firm suggestion here. So I think that's really interesting. I guess some particularly ambitious primary care networks or groups of primary care networks in cities might think about whether now is the time to look at splitting same-day urgent and routine care into different streams and handling them differently using some of this new funding. But it doesn't look like that's being suggested everywhere, which is interesting. No. The sums of money as well are not really enough to do that. If you look at the funding at the level of a city, 10 whole-time equivalent GPs, if that, to be honest, I think that was being generous, is not enough to do that kind of action anyway. So it'd be interesting to see what form the response to this takes.
Absolutely. I mean, we identified earlier that the increase in the IIF funding is £82 million. If you take the population of England to be 59 million patients, that's approximately £1.30 per patient additional to provide this increased level of access, because that's basically the additional funding that you've got, because there's nothing in the core GMS contract that's being offered. There's no additional payments being offered. That's basically the amount of money that, so is the NHS England via the Department of Health via NHS England suggesting that unfettered, universal immediate access is worth £1.50 per patient, because that's kind of how it's coming across. That would be one interpretation you could take in terms of how this looks. I think the challenge is, like you say, what do practices and networks do moving forward? The focus, I think, for many networks is going to be absolutely on that improvement report and getting that done to a degree, to at least try and align to some funding. I think there's going to be some areas which are just going to turn around and say, you know what, I don't really want to do that work. For £50,000 worth of funding, which, important to remember, this is not recurrent funding as well, potentially, because the PCN DES does technically finish next March, and we don't have any clear data on what's going to happen to the additional parts of all this funding. We know that the Rs funding is going to continue. I know we didn't talk about the Rs in great detail. Main reason for that is because that's better covered in our early episode, because not really much has changed. They've just confirmed that all the R stuff from the original letter has continued. But in terms of, the Rs funding is the only part at this point that we know is due to continue covered by the ICBs. every other part of funding, so the capacity access payments, the IIF payments, the PCN clinical director payments, the core PCN payments, all those kind of stuff, that funding table we showed you earlier, none of that has been confirmed to be continuing next year at this point. And I think if it is to be, they really need to be clear that those funding avenues are going to continue, because actually, if you put all these plans into place, say we're going to create a local hub to create support for acute demand, and that funding goes next year, what are you going to do?
It's absolutely, yeah. If you employ 10 more GPs across your city, you may not be able to pay them the year after to continue that service that you went to a great deal of difficulty to put in place. So that's interesting. Just taking a step back though, Gandhi.
Okay.
You know, I guess what we're seeing here, so it's all pending announcements in terms of what changes within the core contract to support this push towards access. But as it stands, there is you know, a large amount of money being given unconditionally to general practice to support access, you know, 70%. And you know, that's I need to get back to my figures, but the amount was you know, not inconsiderable. So that's been given without strings. There is requirement to produce this plan and manage towards this plan, and there's 30% additional funding, again a considerable amount, contingent upon that. The plan actually doesn't look too arduous in terms of making it, and it looks like there's a lot of flexibility to ICBs in terms of interpretation of success against the plan. So in some ways, and there's nothing too firm that we've seen around that 2-week target, which we feel would be difficult to achieve. So far, what we've seen might not be interpreted as being too bad for general practice, dare I say, and people shoot me down, and I'm not sure I fully believe that. But,
well, I think it's not as complex as it could have been. So we're not seeing any national templates. That's an interesting thing. You know, there's no mention of a nationally agreed template. So I think if your local ICB starts coming to you saying, well, you have to fill in this template, that template, blah, blah, blah. Actually, there's nothing, like you said, there's nothing detailed in this. It doesn't say you can just write a simple email saying this is our plan moving forward after discussion with our practices in our network of how we're going to tackle access across our local.
Collaboration and partnership with the ICB. They have a say in terms of whether the plan flies or not as well. So
true, but I think the collaboration also means a two-way street. So therefore, there's no requirement for it to be a specified type of form that outlines that. So I think
however, there is a nationally suggested template for the capacity improvement.
Okay, I missed that one then.
Well, no, it's just what we've just been through, haven't we? I mean, ICBs have been provided with a document that provides, you know, a template of things that you know should be considered for inclusion in the plan. So I think there is a little bit of national stipulation, but I think within that there's a lot of room for flexibility. I think.
Fair enough. Okay. But I think, you know, there's this whole concept of where do you go from here? And I think there's a lot of action that potentially is needed. I think there's also some more data that's needed. So over the past few weeks, me and Andy keep making reference to this report that we've been waiting for. This
just flashing up the template for capacity. Sorry, Dave was just saying, didn't it link a template? It was just that, yeah, it was within the document. Sorry, it just felt relevant.
Yes, effectively. But, you know, we are waiting for some reports. So, you know, the first one is the GP Access report that we've been waiting for since January that still hasn't been released and stuff. There's the Hewitt report on workforce. So, again, Dave made a really important comment about where do these 10 additional GPs come from, even if the funding was sufficient? Well, you know, the report on what the available workforce and changes and all that kind of stuff may be. We're still waiting for the Hewitt report as well. We mentioned that we can't find the change to the GP contract that direct in some of this in terms of the assessment of need and the other kind of context and stuff. So that's still not here. So I think there is some information that's lacking that impacts the ability for networks to you know, crack on with the report. Quite appropriately, Gary Hughes has mentioned the first job for practicing PCNs is start talking to your ICB now. So yeah, if there is going to be a form or a letter or something like that and stuff, then for them to you know, explain what is it so you can capture the right data and that kind of stuff. I'd probably be suggesting have a review of your GP patient surveys from the previous years to look at where each of your practices or your network is benchmarking in terms of some of the things. And is there a unified thing that's a challenge? You know, is it about how, you know, which one of those 5 questions is possibly worth more focusing on? Look at your friends and family test results, because actually if you can lead to some sort of improvement in that as a benchmark, is that enough? And is that around the data capture? Is that around the perspective? Is it different parts of it and stuff from there? And then there's also this review of the whole cloud telephony stuff. So where are your practices, set in terms of the upgrades or changes to cloud telephony? Because actually that's where the ICBs and the NHS are going to be capturing more data from. And if that is not due in the next year, what does that mean for your practice or your network in terms of that capturing of data? Because it's based on when your current contract expires. So interesting stuff in that sense. What do you think, Andy?
Yeah, I think in terms of next steps, I would be having a meeting of PCN leadership and then board and practice representatives, and probably structuring a discussion around the template given in this document to ICBs, the capacity and access payment guidance, to start to populate a table. At the same time, talking to ICBs, starting that conversation with them about it. I think those are the next steps, and then I think the local plan that's appropriate to people's areas will write itself. Probably need to just keep an eye on ICBs and make sure they're not being overzealous and overreaching in terms of what their expectations of the plan are. And I think that's where knowledge of this document is really helpful for PCN leadership. It'd be interesting to see where it goes. The whole thing that we haven't even talked about is what's in the core contract, because we don't know. And actually that people are talking about industrial action, aren't they? And people are talking about all sorts of steps that might be necessary if once the whole picture emerges, if what we're being asked to do is not doable and not practical, which we haven't really touched on today, but have talked about quite a lot in the past. Are there any other comments, Gandhi? That we've had quite lively comments coming through. I'm just
definitely. So we've got some more comments I think we need to go to and stuff. I think just one thing to point out to our viewers that live or recorded and stuff, definitely stick around because we've got one more thing to explain to you that will definitely help with some of this. That's going to be due on the 29th of April. So stick around for that.
So again, I guess people will be left with lots of questions around how they will put together their access plans, what should be in them, and what they should be doing around access. And a lot might change in the next few days as significant documents and core contract might come out, which leads us on to 29th of April.
Yes, so 29th of April, myself, Andy, and friends of the channel, Ben Gowland and Tara Humphreys, who we collaborate with to provide the PCN Plus course for clinical leaders and that kind of stuff, particularly clinical PCN, clinical directors, managers, that kind of stuff. We will be doing a special live event where we'll be reviewing everything we know right before the contract dates change and that kind of stuff. Because important to note, you can technically opt out of the PCN Days contract before the 30th of April. So you've got a day also to do that before then. But in terms of reviewing kind of some of the stuff that we would have had by then, more details and that kind of stuff, we'll be doing a live session where we'll be covering everything we know at that point and potentially helping you review your access reports and that kind of stuff, if that's something that's going to be useful to you as well. So definitely make sure you jump in and join us on that date. The link isn't live yet. We're just fine-tuning it and stuff as usual, but it will absolutely be published on the EGP Learning YouTube channel and various other channels that we have as well. So if you do want to check that, do save the date. We appreciate it is a bank holiday weekend, so you've technically got the Monday off still to join us.
More time to join us on the Saturday.
Yeah, exactly. So in that well-being element, you've got some extra holiday time, so don't fret about having to spend it joining us. I mean, it's just purely because unfortunately May has 3 bank holidays, so the reality is a weekend time is going to
it's the timing of some of these deadlines as well imposed by NHS England. Got to
get 12 weeks. 2 weeks later you'll have to submit your access plan and stuff and things. So definitely make sure you jump in and join us. We'll put all the links to that and the various different reports and stuff down below in the show notes. So if you do want to check those out, particularly that one that Andy mentioned that has been directed towards the ICB, so you may not naturally be looking at it, but is actually the post that you need to achieve and that kind of stuff, then do check out the links down below. And when we have the link to the session on the 29th of April, we'll put that down there as well, so you can track that if you want to notify and register for it, although it'll be free access through YouTube and all our other channels and stuff like that.